Hello, and welcome to Medical Radicast, your source for news and radical ideas about medicine and healthcare. To my more conservative listeners, some ideas will be radical because they diverge from mainstream medicine. To my more alternatively inclined listeners, some ideas will be radical because they merge with the mainstream. Either way, stay tuned, listen in, appreciate something known, and learn something new. I'm your host, Mitchell Cohn, Doctor of Osteopathic Medicine and Medical Radical. Here at Medical Radical, we seek to inform, entertain, and inspire you to take action to improve your life, your health, your community, the environment, the world we all share. Today's main topic: what I learned at a recent American Osteopathic Association Prolotherapy and Regenerative Medicine Conference, and why bucking the trend toward, quote, evidence-based medicine, unquote, may provide the only hope for real cures for health problems like chronic pain. But first, weird medical news. For this, I'll be joined by my wonderful wife and occasional podcast co-host, Elena Diamond. Hi, Elena.
Hi, Mitch.
Why don't you go ahead and start on the first story here?
Okay. This first story was from the Mirror in UK, and it's called Kiss of Death, Defiant Farmers Still Smooching Camels Despite Deadly Virus Warnings.
Did you say smooching?
I said smooching.
Smooching, okay.
The deadly MERS virus that are associated with camels and possibly bats.
And MERS stands for Middle East Respiratory Syndrome.
Found in lots of camels and maybe animal reservoir in Saudi Arabia. There's been 500 cases, with approximately 1/3 of those cases being fatal. Farmers, however, aren't listening to the authorities when they're telling them not to kiss their camels, and they're kissing them even more, and have gone on a rampage of snapping selfies, kissing their camels, and encouraging their camels to sneeze on them as well.
So farmers in Saudi Arabia who have almost nothing else all have cameras with which to snap selfies kissing camels.
Yes.
All right.
Yeah, this will probably be the plague that wipes us all out, and it's all because of camel farmers. Coming from tabloid might seem weird, but the research shows that in May of 2014, National Geographic backed up the claims that camels are the most likely hosts of the MERS coronavirus, and the farmers may be playing with viral fire.
Okay. All right, thank you. We're going to move on to the next bit of weird medical news, and it's titled Bullying and Health. Bad for victims, good for bullies? From Live Science at livescience.com. There was a study published in May of 2012 in the Proceedings of the National Academy of Sciences. The article states, and I'm quoting here, previous research has shown that childhood bullying victims may experience social and emotional problems as adults. No kidding, right?
Yeah.
However, bullied kids also tend to experience physical problems such as pain and report getting sick more often than kids who are not bullied. What did you say about the kids getting sick?
If they're studying children in school, if I was being bullied, I would stay home all the time because I'm sick.
Okay.
I'm sick. I don't want to go to school. I don't want to confront the people who are bullying me. If they're talking about later in life, obviously it's a residual effect of the bullying. It stays with you.
Right. And they did do this over a 20-year period, and it showed that the adults, these kids who had been bullied as children, as adults, showed higher levels of something called CRP, which is a measure of an inflammatory problem, and they had higher levels of this inflammation than the kids who had either been bullies or kids who had been both victims and bullies. So the kids who had been victims and bullies were somewhere in between. So health and bullying data from over 1,400 people collected over this more than 20 years showed this increased CRP. And my question is, what do we tell our kids now, saying, don't bully, and yet they're finding bullying may actually help some of those kids?
Well, I'm going to have to go back and look at all my C-reactive protein, CRP, results and see where I landed, because I was both bullied, but I also took care of the bullies who bullied me.
Okay.
So maybe this is Darwin's way of weeding out the weak, maybe?
Maybe. I don't think this is an endorsement of bullying. My question is, maybe if nobody does any bullying, then nobody may be at increased risk for inflammation.
That would be idyllic.
Yeah, it's just a thought. Okay, our next story, which isn't just weird, but I'm going to call it creepy medical news, comes from the Des Moines Register. And my worst fear is realized. Mosquitoes on the rise. I hate Thank you. I hate mosquitoes. I'm allergic to mosquitoes, but they think I'm dessert. But even more weirdly, this was reported on by a Dr. Yogesh Shah, who's an associate dean for global health at my osteopathic medical school alma mater, the Des Moines University College of Osteopathic Medicine. Quote, of all humans who have died in our history, 50% have been because of malaria, unquote, he said. Malaria infects about 200 million people a year and causes 600,000 deaths, mostly in Africa and mostly in children. And he goes on to say that every increase in temperature by 1 degree, I think he means 1 degree Celsius, can increase the mosquito population by, quote, almost 8 to 10-fold, unquote.
Wow.
Yeah, that sends shivers up my spine. The number of malaria cases in the United States is small but growing, with a 50% increase between 2008 and 2011. Other mosquito-borne diseases likely to get me, because they do think I'm dessert, are a dengue fever. Oh, I can't even pronounce this one. Try that.
Chikungunya.
Thank you. And West Nile virus, which we all know is present in the U.S.
Yeah, that's a biting article there.
Thank you.
The next story is also from the Mirror. Great news if you're short, fat, bald, and smelly.
Oh, I've got that covered.
No, well, not all of them.
Okay, I'm not smelly.
Some of the benefits going to gray, bald, fat, or even smelly. Short men are likely to live longer due to an expression of a protecting gene called FOXC03.
Oh, does that mean I'm foxy?
Well, this surprised me because I always heard that tall men made more money. So apparently tall men make money and then die really
so
quick.
You still should have married a tall man.
Well, I guess it has its advantages. It depends on how you look at it. Short women, I think, honestly, short women less likely to get cancer, so that's good. I have that on my side. According to the Oxford University study published in the Lancet Medical Journal, I think this story's leading toward the fact that hobbits live longer. Unpopular people, well, this was kind of, I don't know, I kind of looked at this and went, duh. But unpopular people are less likely to be infected with bugs because they don't come in contact with people.
Well, that explains why I'm fairly healthy.
Baldness. In men, high testosterone levels are thought to be linked to male pattern baldness, and a study in the University of Washington also found that men who develop bald spots and receding hairlines have a 29 to 45 reduction in the risk of developing prostate cancer. So that's a plus.
Okay.
Captain Picard has no worries down there. Big noses.
I do have that covered.
Big noses. Surprisingly, having a big nose means you're less likely to become ill as a result of breathing in germs. I would think you breathe in more germs, but
that's what they thought in the article.
But the University of Iowa research showed bigger noses may serve as a barrier to germs.
And I'll bet it's the greater number of nose hairs, because I know I have a lot more of those, in a longer nasal passage. So don't cut them or pick them anymore.
So you've got a longer filtering system.
Exactly.
You can find more info on all the things we've been sad about having, which now may turn out to be a good thing. Going to www.mirror.co.uk/news/weird-news.
All right. And our last weird medical news story, actually, this has been in the news, believe it or not, for, well, when my research shows it goes back at least 2 years. Fecal transplants. Yes, folks. Fecal, as in poop, transplants.
That's deep.
Reported in numerous reputable medical and layperson journals, including Scientific American, Discover Magazine, Huffington Post, and many more, and even the National Institutes of Health, and endorsed by the Mayo Clinic. Transplanting healthy, helpful bacteria from healthy individuals to unhealthy people may help or cure a number of problems, including ulcerative colitis, Clostridium difficile, which is a very difficult to treat diarrhea, which often results from antibiotic treatment, chronic constipation, irritable bowel syndrome. This one I thought was very interesting, Parkinson's disease. It's not exactly in the bowel. Various autoimmune conditions such as multiple sclerosis, rheumatoid arthritis, even type 1 diabetes, and possibly chronic fatigue. And there were actually a number of other things listed in the articles which I reviewed. An NPR report from September 5th of 2013 quotes biologist Jeffrey Gordon of the Washington University School of Medicine in St. Louis and his colleagues when they removed bacteria from the guts of 4 pairs of human twins, in which one of the twins was obese and the other was lean. The researchers then transplanted those microbes into the guts of lab mice, not into the other twin, into lab mice who didn't have any of their own gut microbes. The mice that got microbes from the fatter twins gained more weight and fat even when all the mice ate identical diets. That's pretty interesting. Then the scientists let the animals live together, and I'm quoting here, and since eating each other's feces is a common habit among mice, they were soon exposed to each other's gut microbes, unquote. Lo and behold, the fat mice picked up the lean microbes and they lost weight. And finally, the researchers showed that the animals were unable to be colonized by the lean microbes when they were fed diets aimed at simulating a typical unhealthful Western diet high in saturated fats and low in fiber, which means these animals, even though they were given the microbes from the lean twins, still got fat eating the diets that you and I eat. Although we're trying to be better than average, it explains where I am. But anyway.
So this pretty much says that big girls should follow Paris Hilton around and into the bathrooms.
That is a disgusting thought.
It makes sense in my head a little bit, but the thought of getting a fecal transplant is a little off-putting.
Well, I understand that, but you know what? Believe it or not, they're now working on fecal pills that you can take. I hope they're capsules.
Yeah, me too. Yeah.
All right, in any case, don't try this at home. I don't think having your spouse's lean microbes is going to make you any skinnier.
I'm sure there'd have to be some processing put in place to
I think
make
so
this
too.
work the right way.
All right, we're going to take a short break and we'll be right back. We are back. I appreciate your help, Elena. Thanks. She will be back later on in the podcast. For right now, I'd like to talk about the American Osteopathic Association Prolotherapy and Regenerative Medicine Conference that I went to last week. It's going to be a little more rambling, but there's some really interesting points that I want to cover. The first is, it was really amazing to me to be in a group with such like-minded people. Many of them were MDs, not DOs, and people came from all over the world. We had people there from the Philippines and Thailand, Canada, Mexico, Hong Kong, Italy, and I don't know where else. And there were only about 50 of us. But the things that I wanted to say are, first of all, I admire all the MDs who were there. They were thinking way outside the box. But there was a noticeable difference. Okay, well, there was this one guy. His name was Dr. Stan Lamb, a tremendous lecturer who's an MD, and he lived in Hong Kong. I don't know if he was trained in Hong Kong originally. He also lives in the U.S. at least half-time and practices in both places. But he's also trained in osteopathic manipulative medicine, I understand, through Michigan State University's College of Osteopathic Medicine. He also does prolotherapy and PRP, which are some things that we have discussed and will discuss in the future in more detail. He does something called hydrodissection, which is really cool. We saw ultrasounds that showed how you could stick a needle in next to a nerve and just essentially squirt kind of a sugar water in there, and it would separate the nerve from the tissues and break up scars, and you could instantly get rid of pain. It was a beautiful thing to see. He does use the occasional dry needling, which is just what you do like in acupuncture, but he avoided talking too much about that because he didn't want to talk about qi, which I found interesting. He explained qi, which a lot of people know as related to energy or health or vitality. He explained it more as an electrochemical process or even allowing or releasing gas into the area. Anyway, very interesting stuff, but he was not a Chinese medicine practitioner. He is an MD, but he incorporated all of these things, including osteopathic treatments. Still, there was a noticeable difference between those who were MDs, who were not used to using their hands for palpation to diagnose. It's a nice fancy medical word which means using your fingers to touch, to feel things to diagnose. But there's a difference between the MDs who were not used to doing that and the DOs who have done so on a regular basis. You could tell who were the practiced palpators and interventionalists. But what was really important was a couple of things. Some important takeaway points from this conference. I was taught in residency that once the body has developed chronic pain, that it makes changes in the brain, and those changes are things you can see on what's called a functional MRI of the brain. And even if you fixed the cause of the pain or got rid of the limb that was injured, those pain sensations would always be present because the brain had been changed to register pain and would always register pain no matter what you did for that person. But in my 27 years of being a doctor, I never found that to be true. If I found someone, even if they'd had pain for 40 years or more, if I could find a cause for their pain, a vertebra that was flexed or that was held in place by a scar, a muscle that was contractured, which means contracted, like spasmed for a very long time, in some cases for 30 or 40 years, or a damaged ligament, if I repaired it or set it right, their pain went away. And so I couldn't adhere to this, quote, common wisdom, unquote, that's still spouted almost everywhere, at every pain clinic, at every spine and pain institute. They say, well, we can't get rid of the pain. We can cover the pain, but it's in your brain. And there was actually a Discover article about this recently, believe it or not. And not only did this group at the AOAPRM meeting not believe it, and honestly, I'd always thought I was alone in my experience. But apparently some of them found that there is we'll call it a new train of thought going through pain circles, where now at least a few researchers believe that pain is never really what they call centralized, meaning it's never really in the brain. Yeah, you can see it on the functional MRI, but it's just showing that you register pain. But that does not mean the pain has undergone a permanent change that will make you register pain all the time. They believe that there is always a peripheral cause for the pain, meaning somewhere outside the brain, and what we need to do is find it and fix it. I felt so vindicated. It was amazing. Now there's another problem, what I call the pebble in the shoe. And I'll tell this story very quickly. I tell it to a lot of my patients. A man is walking along, and he's just fine. Suddenly he gets a little pebble in the shoe, so he leans away from that foot. But he keeps walking. After a little while, he gets a pain in one side because of walking a little funny, so he twists a little bit, and he keeps walking. Now that he's twisted, he's starting to get pain in the neck because he's all twisted up. So he twists a little more, gets his head a little resettled, and he's doing okay, and he keeps walking. And this goes on, and 3 years later, he's got the worst headache of his life, and nobody can figure out what the problem is, because everybody's looking at his head to find the cause of the pain. But the cause of the pain comes from that pebble in the shoe. But you layer compensations. He compensated for the pebble in the shoe, then he compensated for the new pain in the side, then the new pain in the neck, and so on. So you need to peel those layers off. So in other words, one injury, no matter how small it is, can set you up for future injuries if that initial problem isn't taken care of. If you don't take the pebble out of the shoe, you will probably have problems down the road. So, if, despite having no specific treatment to correct a problem, a person with pain adapts and becomes pain-free, at least for a time, though the problem hasn't been corrected, it can set them up for future injury and pain, which may even seem unrelated down the road. Like I was saying, headache from a problem with the foot. Now, another thing was there was a gentleman who, like me, does nothing but hands-on medicine, treating chronic pain, acute pain, etc., with manipulation and with prolotherapy and such. And I've always felt, well, I couldn't put it into words well. I couldn't get it out. But I felt that I never liked this idea of what they call evidence-based medicine. Now, evidence-based medicine sounds like it makes sense. Everybody touts this evidence-based medicine as the only way medicine is kept scientific, as the only way you should ever be convinced to change your medical practices. You've got to have the studies. You've got to have the numbers. Now, there are severe problems with this, and I just couldn't figure out how to express them, to define the problems. For instance, for going on 30 years, I have seen miraculous recoveries from chronic pain. Just go to my website, www.mitchellcohn.com. That's MITCHELLCOHN, all one word, .com, and look at some of the video testimonials to get a small idea of what I've seen. According to this doctrine of evidence-based medicine, though, I should ignore what I've seen and experienced. I haven't done rigorous scientific studies. I've just treated people and made them more functional and pain-free. According to the doctrine of practicing only evidence-based medicine, I shouldn't have been helping these people with my hands or my needles. I should have been sending them for tests and more tests, which would show nothing was wrong, and for surgeries that wouldn't work, and for medications that would simultaneously fail to actually make them better, but would addict them nonetheless. I'm sure this would have made the pharmaceutical companies and the spine and pain clinics, the surgeons and the hospitals quite happy. Even for the few studies that were done on osteopathic manipulation in a fashion that was acceptable to the medical establishment, there were terrible flaws and the conclusions were awful. But those flaws allowed the medical establishment to feel very good about itself and the useless treatments that they were perpetrating upon the public. Now, let me give you an example. There have been, I believe, 2 studies that got published in JAMA, the Journal of the American Medical Association, which, as you know, has nothing to do with osteopathic medicine. It's all MD, or what we call allopathic medicine. And those studies showed that osteopathic manipulative medicine, or OMM, was, quote, as good as, unquote, MD medicine for low back pain, but only as good as. God, that bothered me. I always found so many flaws with that logic. The first was the studies always talked about how the patients were 6 months or more out from the original injury. The truth is, most people, regardless of the injury, will generally heal or adapt, as I talked about in the pebble and the shoe story, to the injury without going into a chronic pain state. Most will heal or adapt without pain between 3 and 6 months out, even if you do nothing for them. But good osteopathic treatment early on means these people don't have to suffer or wait for 3 to 6 months before their pain is gone. We might be able to remove the pain in 5 minutes, or put back what's wrong, or get them pain-free and fully functional within 2 weeks, but not necessarily 6 months. Now, here's a good place for me to insert the featurette, Osteopathic Moment, and then we'll continue with the story, but I think this is important here. I had a gentleman come into my office, a big man. He had injured his back 11 years before he came to see me. He couldn't lie down in a bed. He couldn't lie down on a floor. He had to sleep sitting up in a chair for 11 years. No MDs could help him. And as soon as he presented to me and I did my examination, I knew what was wrong with him. And honest to God, it took me 2 seconds to fix him. And he was amazed. Now, a few months later, he got a completely different back injury. He had a muscle spasm, which had absolutely nothing to do with his original injury. Wow, that took me, I think, 15 minutes of work. But you got to remember, this is a big man, so it was a lot of work. 15 minutes. And then he was done. And a few months later, he came back with back pain. And guess what? This was unrelated. It wasn't even in the same region of the back that he had before. And I literally had it fixed in 2 minutes. So the point is, there was never a good comparison of short-term versus long-term outcome in these studies. And I've always had problems with other things, like patient selection. The doctors participating in the study would take and randomly assign patients with any undefined low back pain, and they would put them in treatment groups or non-treatment groups. But that's not the way you should do it. You have to pick patients that are appropriate for treatment with osteopathic manipulation. Not everybody is appropriate. If a person has a torn ligament, osteopathic manipulation is not by itself the proper treatment. But that's what they were doing. They were throwing people into these different groups. To do it properly, the patients first need to be examined, and it needs to be determined what type of injury they do have, whether it's a ligament that maybe needs prolotherapy, or a vertebral dysfunction, as we call it, meaning they got a flexed vertebra that's stuck, or as chiropractors call it, subluxed, which is really a misnomer, but we won't go into that, or whether they have a muscle spasm that can be easily fixed by appropriate stretching. And then you put them into these groups and say, those that have lesions that are considered treatable by OMM, in other words, good patient selection based upon diagnostic criteria. And then ask the question, are they better off if they are treated with OMM or left to recuperate with various other therapies such as physical therapy, which is essentially random, injections, medications, a watch and wait type of treatment, etc., which are the most frequently utilized therapies by MDs, I should add. The watch and wait, the physical therapy, medications, injections. Not only that, but what about the expertise of the operator, meaning the physician? When I was fresh out of school, and even when I was fresh out of my postgraduate training, I had nowhere near the expertise that I have now. I can diagnose and treat things with my hands now that I could never do before. I can recognize things now that I never could before, so operator experience is just as important as, say, operator experience in doing gastric bypass surgery. Surgeons with relatively little experience have far more problems with diagnosis and treatment and far more complications than people who perform the same procedures but have far more experience. There was a surgeon, when I was in my internship, I observed this guy who was new to laparoscopic gallbladder removal, and he was terrible. He constantly nicked the gallbladder and leaked potentially infected bile into the abdominal cavity with a potential for causing deadly peritonitis. In the 3 surgeries I observed this guy do, he damaged the gallbladder and leaked bile every single time. Now, 5 years later, I'm sure he had done hundreds of these, and I doubt he was still having the same problems. The point is that operator experience has a lot to do with whether or not OMM is successful, just like whether or not surgery is successful. These kinds of things were never, in my opinion, taken into account. These confounding factors were never addressed. So the thing that the doctor I was speaking to at the AOA conference expressed so beautifully was this. He said he hates and does not agree with or believe in this idea of evidence-based medicine, which is touted so loudly and used to make hospital guidelines and practice guidelines and determine whether insurance will pay for particular treatments, because in order to be considered, quote, evidence-based medicine, unquote, a study, or more likely many studies, about the subject or procedure have to have been published in peer-reviewed journals, and usually multiple peer-reviewed journals, and they have to have multiple studies, and things like osteopathic manipulation are never going to have that. Very few studies will ever be done that will meet criteria for publication in prestigious medical journals, and even when they are done, we end up with garbage like those 2 JAMA reports, which say OMM is as good as standard medical garbage treatment because the studies were not really properly done. This doctor said that the studies that do make it into these journals are included only if they meet the criteria, and get this, and the agenda of the editors. And these editors are, first, generally MDs. They are generally anti-CAM, and CAM stands for complementary and alternative medicine. And they must consider their journals' backers and advertisers, who are primarily pharmaceutical companies, medical device companies, and corporate medicine companies who do not wish studies that do not enhance their profits to be published. Now, unfortunately, there's literally no profit for such companies in promoting OMM, prolotherapy, neuroprolotherapy, etc. As medicine and medical devices are not generally used or promoted for these treatments, physical therapy and hospital visits and stays are reduced or eliminated, and recurrent fees for spinal and chronic pain centers would actually be reduced. This provides a marked disincentive to publish positive CAM or OMM or prolotherapy articles or such. There is really only a single osteopathic journal in the entire United States which publishes osteopathic-related research. So 99+% of peer-reviewed journals almost exclusively publish articles which further the agendas of corporate and pharmaceutical companies. The things doctors like me do, however, make people better and less dependent upon chronic treatment and therefore do not advance those groups' agendas. So I know I can cure somebody that someone else might not be able to cure using standard treatments based on, quote, evidence-based medicine, unquote. But what I do is never, well, at least not in my lifetime, going to be considered mainstream medicine or part of evidence-based medicine. Even though we have multiple studies, they're never going to be accepted for publication or published widely enough to impact how medicine is practiced. Also, going back to the MDs that I do admire, like the ones at the conference, and really, it's a wonderment to me that these people are willing to go out on a limb and do these things and work with their hands and try a whole new way of practicing. Some of them may have been in practice for 10, 20, 30 years, and the problem is this. They're trying to think holistically. They're trying to think neuromusculoskeletally like DOs are supposed to think. And I'm very proud of them for that. But they've got a late start. Some of them, if they start young enough, may get to be very good. But for the most part, they will have lost 20 or 30 years of training compared to a DO who is essentially given this training as a gift, as part of our education from day one in medical school. And these MDs think and try to act more osteopathically, holistically, and sensibly than most of the members of my own osteopathic profession. If we could just get osteopaths to think about manipulative medicine, about neurological, musculoskeletal concomitants associated with organ problems, if we could just get osteopaths to think about osteopathic manipulative medicine or approaching a problem holistically and get that to the forefronts of their minds instead of either a last thought or no thought, we would still be way ahead of even these MDs who are trying to catch up. But what's odd is that these MDs, these late bloomers, are going to be ahead of many DOs, the majority of DOs, in fact, because DOs no longer think as a group, as osteopathic physicians have been taught to think. I think that's a very sad thing for our profession, because we have so much to offer, but we are now having to train people outside of our profession. Not that I'm against sharing this information, but we have to, we are forced to train people from outside our osteopathic profession if we are going to keep osteopathic style manipulation and osteopathic thought alive. And that is sad, and it shouldn't be that way. Let's take a short break. We're back. For the last part of today's show, we would like to do a public service announcement. At least we think it's a public service announcement. It's about medical marijuana. Cannabis can be really helpful. Now, I did medical marijuana evaluations, physical examinations, and certifications for years, ever since it became legal in my state. I had to fight the bad guys in the government who didn't want this to go on. I had to fight the bad guys in the medical marijuana business. There were some people out there who were simply weed peddlers, and they really didn't care about the medical side of it. And I had to fight doctors who, I am sad to say, were simply out to make a buck and really didn't have any medical ethics. But I went and I studied medical marijuana. I went to conferences. I learned some amazing things. I even wrote a brief book on this. Turns out that the cannabinoids, they're just one class of chemicals, can be used to cure skin cancer. And the cannabinoids, this is not the THC, which makes everybody high. The cannabinoids are a different part of the marijuana chemicals. They work amazingly well for things like seizures, which we'll talk about in a second. And I learned that people who have chronic pain don't have to get high. They don't even have to get a buzz to get pain relief, and so much more. Now, ever since this started back in, I think it passed in 2008, my state's been trying to make it harder and harder to get and to stamp out medical marijuana. They finally seem to have come to some kind of agreement. There's a middle ground, but I certainly don't see it becoming a widely legal substance here. But there's some rather interesting news, and I think I'll let Elena take it from here.
I recently heard on a TED Talk a group of brothers, they're biochemists, and they had bred medical marijuana with no THC. So it had all the, you go ahead and say that word. Cannabinoids and other chemical constituents, but not the THC.
THC?
Yeah, no high.
We can't get high.
Right. But virtually in all the cases and for all the causes, that it's needed for. So the Weedmeisters, they lose out in this. However, the TED Talk detailing what they'd accomplished showed how this non-high cannabis is so effective at helping people. It had example of children with seizures that had seizures every few minutes.
I have to say, this was amazing. It was. On the TED Talk. You have got to see this. They showed kids who lived in a perpetual fetal position because they couldn't move. They were having
their whole life. Every 15 minutes they were in a seizure.
Or less.
They couldn't learn. They couldn't exist other than in a seizure state.
Right. They didn't know if they had personalities because they never came out of the seizures.
But on first treatment, the seizures stopped.
Very first treatment.
Wow. And stopped, and with subsequent treatments, virtually cured. Mm-hmm. In some cases, with no more seizures.
No more seizures, and no more of the other medications they'd been on?
Right. They were on bottles and bottles of pills. Lord knows what the side effects were of
that
those.
Never worked.
That didn't work anyway. They never stopped the seizures from happening in these poor kids.
So it's an amazing, amazing treatment we're talking small children. Now, these kids are not getting high.
Nope, not at all.
They are only getting the medicinal benefits.
This is actually a miracle drug.
I agree.
And we should be shouting it from the mountaintops, but it's still illegal to ship. They're still treating it as a drug, even though the high is taken out of it. So there are kids contacting this group of brothers, and we don't have their name here, but we've got the link to that will be in the notes of the talk. But these group of brothers are being contacted, hounded by parents across
from all over the world,
saying, please help my children here, please send me the drug, I'll pay you. And they can't. They'll end up in jail because it's illegal to ship across state lines. So the only thing that can happen is all those people have to find a way to get to them. And in one of the cases, one of the families, they had no money to get their child there, and their child died.
That is very sad. So they either have to be wealthy enough and or mobile enough to move to, is it Colorado they're in?
It's in Colorado.
It's in Colorado. You have to either be able to get there, or your child will suffer for the rest of their lives. It's a very sad story, but it is amazing to see what these young men have done.
Well, you've never seen a pharmaceutical pill work like that. Right. In one dose, you're better.
Right. So, there will be a link on my website, mitchellcohn.com/blog. We'll have a link to the TED Talk. I strongly, strongly recommend you watch it. It is both sad and uplifting at the same time, and it gives me a great deal of hope for many people, kids especially in this case, who suffer terribly, and a little medical marijuana can go a long way. And
when you watch the TED Talk, I think there's a link to these biochemist brothers, their site, and they are taking donations. It's a very worthy cause. I help them figure out how they can get this to more people, how they can change the laws, or help bring other people to them who can't afford to get to them.
All right. Elena, thank you very much.
Thank you, Mitch.
I want you to know your feedback, comments, concerns, even personal stories are welcome. You can either write to me, Dr. Mitchell Cohn, at medicalradical@medicalradical.com, or you can call and leave your feedback, comment, or story as a voice message on our Skype line at 734-931-MRAD. That's 734-931-6723. Your voice may even make it onto a future podcast. Thanks for listening to Medical Radicast. I hope you've learned something you didn't know before, been entertained along the way, and will now maybe even take action to improve your health or healthcare, whether doing a little research, looking for a new doctor, or even just being willing to ask more questions to the people you've trusted with your healthcare for so long. Your health is in your hands, and that, my friends, is a radical idea. It's been my pleasure to be your host on the Medical Radicast. I look forward to speaking with you next time. This is Mitchell Cohn, D.O., the Medical Radical.
I got out my bed early this morning. Down the road I go. You know I love you, baby. That is you. You know I love you, darling. I give you everything you need. Well, my baby, she used to lay. Now, just take it easy, baby.